Welcome everyone to Healthcare for All, brought to you by WCANradio.com. This program examines the issues of healthcare for you. Join us now in the studio where the program is in progress.
Welcome to Healthcare for All, sponsored by SPAN Ohio. This is Debbie Silverstein, your host, and I am in the WCAN studios with my co-host, Eric Meadows. Hi, Eric. How are you doing today?
I'm doing wonderful today, Debbie. You know, I thoroughly love this show, and I love the amount of information that all of your guests have been able to bring to the show. We've had some response from a lot of our listeners, and, you know, we do like the idea that WCAN has become a hub for healthcare, bringing all the states together.
And I'll tell you, we are very thankful that WCAN has done this for us, and, you know, you've given us a voice that goes all over the nation when we're talking about healthcare issues, and we're talking about, you know, not what do you do for the common cold, but we're talking about how do people access healthcare, how do people afford healthcare, what do we need to do to make this system a more humane system than what the one we have. I find it dehumanizing it a lot of times.
Well, you know, I'm being informed every month. But, you know, like I was saying about your guests, they have been very interesting. They've been extremely knowledgeable. Who do we have tonight?
Tonight our guest is Dr. Brad Cotton. He is an ER physician. He's a member of Physicians for a National Health Program, and he's an occasional columnist for the Circleville Herald in Circleville, Ohio. He has done, he has put together a display that he did down in Circleville called Eyes Wide Open Healthcare, and it was patterned after the display Eyes Wide Open on the Iraq War, where we had pairs of boots, pairs of shoes that represented every lost serviceman in Iraq. And he did this on the healthcare issue because of the number of people who die because they can't access our healthcare system. And so we're going to be talking to him tonight about that, and then as an ER physician, his experiences and his thoughts on our healthcare system and what we need to do instead. So Dr. Cotton, welcome to the show.
Oh, thank you for having me.
Well, we're very pleased to have you. Why don't you start out by telling us a little bit about Eyes Wide Open Healthcare?
Well, first of all, you referenced the Eyes Wide Open regarding the Iraq and Afghanistan wars. That was sponsored by the Quakers, a faith that I also come from. I don't necessarily speak for all of them, but that background. And it was called Eyes Wide Open. The idea was that when we put a pair of combat boots out for all the servicemen in Ohio that were killed in Iraq, and a large collection of civilian shoes, which was sometimes very touching, putting children's shoes and so forth out there to represent the Iraqi civilians killed, that it would open our eyes, and people experienced that exhibit very powerfully, to come by and actually be confronted with not just raw statistics, but these empty boots with the servicemen's name from Ohio who had been killed in Iraq, and the civilian shoes. The idea was that the healthcare situation comes from a similarly moral background. I mean, we feel it is wrong what happens in our country, people that are shut out of our private profit-based healthcare system. And roughly about 50,000 people a year in the United States die directly attributed to the lack of health insurance. That was from, I believe it was December 2009 American Journal of Public Health, some research done by Physicians for a National Health Program. Breaking that down, Ohio, that would be about 1,650 deaths. So we had about 400 crosses just to represent a portion of those, put them out on the courthouse plaza with some signs announcing that this was to represent Ohio deaths for lack of health insurance. And we got, the passersby, many of them came and talked and interacted with us, and hope we did open a few eyes, which was our hope.
Well, it's very easy when it's just a number, like 1,650 Ohioans we talk about, and that's just a number to people. But when you put those crosses out, or when you put the boots out to represent those servicemen, it brings it a little bit closer to home, and it makes those statistics live, or at one time living people.
Yeah, it's difficult. I'd have to say it's difficult at times as an emergency physician working in the emergency department, which is the only place that many people can come to get any kind of care, to be face-to-face and heart-to-heart with these people who are suffering. We think there's 1,650 Ohioans die every year from lack of health insurance. but immensely more suffer from conditions that they're not adequately treated for. They skip their own medications so that they can afford, their children's health care. It's very sad that in our country that the care that you get and the life that you live, and even how long you live, can be determined by your economic status.
Dr. Cotton, I'd like to ask a question. When you first presented your display, were people shocked at hearing, these numbers, and shocked at knowing that across the country that health care is in fact a major issue?
I think our response was I think we opened some eyes, and the people that came and stopped and talked with us, again, what tends to happen, these things, the people that disagree with you or are hostile tend not to talk, but a number of people came by and talked with us. I can think of one woman in particular that worked for a health insurer, and we had a long conversation about how she felt and what it felt like for her to have to turn people down for health insurance. She was fully aware of what the consequences would be for these people that she was trying to help and couldn't, because they didn't qualify for health insurance under the Patient Protection Affordable Care Act is not fully enforced yet in all aspects, and people can still be turned down for a lot of conditions.
Well, I thought it was wrong for hospitals to turn away people that couldn't afford care.
Yeah, and that is, boy, that's interesting. That has been cited both by George Bush and by Mitt Romney during the George Bush and his presidency, and Mitt Romney during the recent campaign, is precisely that feeling, is that, well, for health care, you just go to the ER. Well, in the emergency department, we are the ones we are the overwhelmed lifeboat of a sinking healthcare system. And I see everybody, when they've crashed and burned, have gotten in big trouble. And basically, if they're sick enough, I admit them to the hospital. If they don't meet criteria to be admitted, they are discharged home, but they're just going to crash and burn again. I cannot, in the emergency department, take long-term care of people with diabetes and high blood pressure and other medical conditions that need other testing and other follow-up. And I can take care of the crashing and burning and try to put a Band-Aid on a problem, but to think that the emergency department can be the full delivery of health care, that's an unfortunate way of looking at things that is often cited by those who oppose universal health care coverage.
But in a sense, when we recommend that people just go to the ER, I remember the one quote, you need health care, well, just go to the ER. But that's an irresponsible use then. It's promoting an irresponsible use of the ER, because that's emergency department, it's not everyday health care. You don't go there because you have a sinus infection. You go there because maybe you suspect you might have appendicitis or a kidney stone or a broken leg or something like that. But when we turn our system into one where you have to go to the ER to get treatment for a simple condition, then that's where we're causing a lot of that overload in the ER, isn't it?
That's been debated. I tend to, everybody that comes to the ER, they come there because they felt that they needed to be there, and for many of them, they had no other place to go. It's easy sometimes to get aggravated. Say, for example, 3 o'clock in the morning, that mother brings a child in with a fever, but then when you look at it, she was working. She had no other time that she could get her child to a physician, and sometimes people set their alarms and get up at 3 o'clock in the morning because their only way they ever going to see a doctor is to come to the ER. We are the only set of physicians and the only place in America outside of free clinics and so forth that treat all comers. We don't. We do get, eventually people ask questions about insurance and payment, but that's after we've taken care of them. And I'm proud to work in that kind of setting. I wouldn't work anywhere else. So I tend not to look at people abusing the ER, although, economically there are arguments that if we had more primary care doctors, and some countries like Canada, for example, have more primary care doctors per capita than we do in the United States, that some of these people could certainly be cared for, and indeed would get better care, better longitudinal care, for their long-term conditions with a primary care physician. But they have nowhere else to go but the ER. And I wish we could do it all, but we just can't.
Well, Dr. Cotton, now there are other alternatives. I mean, there are primary care physicians, and you do have Medicaid and Medicare that is available. Are you finding that a large portion of the public is using the Medicaid? And if they are using it, are doctors actually accepting it?
There's several points there. One, we just do not have enough primary care doctors in this country, and that's because people graduate from medical school with huge loans. Primary care doesn't pay well, so they go into lucrative specialties. Our whole system is upside down. We have a number of very high-priced specialists and just not enough primary care street corner doctors. In fact, often people will come to the ER because they will call their primary care doctor who's already overwhelmed and can't fit them in for an appointment, so they come to the ER instead. So our whole system in Canada and a lot of other countries have universal health care is better designed. There's more primary care doctors and less specialists. Medicaid, a lot of physicians just will not take that because the pay rate for it is so low. There's been a lot of studies done. I know one that was published by Physicians for a National Health Program where they tried to make appointments for a child to see a specialist, and if it was a Medicaid patient, they would get an appointment in a month or so. If it was primary insurance, they would get an appointment within a week.
Oh wow.
So there's and Medicaid in some parts of the country pays so low, it might as well be uninsured.
Mm-hmm.
Okay.
And depending on where you are in the country too, in Ohio we actually have one of the more liberal Medicaid programs. In Texas, it's hard to get Medicaid if you're over 25% of poverty, except for special conditions.
Yeah.
Can you believe that?
It's interesting you say that because I was saying what I was thinking is that Medicaid rates are so low in parts of the country, the payment rates, and the bar is so low for income. In Texas, Louisiana, a lot of those states are some of the worst of the people that they just leave out of the system.
Mm-hmm. They've got some of the highest numbers of uninsured, and yet those are the states that said no to a Medicaid expansion right away. The primary care doctors, you said other countries have more primary care doctors per capita than we do.
That is correct. The one statistic I know offhand is Canada has an average, if I recall the statistic correctly, about 20% more primary care doctors per capita than the U.S. does, and that is improving as the effects of the Canadian health care. It always takes a while to turn this around. Takes effect. People in Canada see their primary care doctor more often than we do in the United States. When they are sick, they get to stay in the hospital longer. They're not booted out quite so fast, and they enjoy better health rates largely as a result.
Well, now that one of the arguments against a Canadian-style healthcare system is that the doctors were fleeing Canada and coming down here to practice because of their system.
And there are a lot of what is the term of statistics don't lie, but liars use statistics.
Okay.
There was a brief time, I think during the 90s, when there was some physicians leaving Canada, and if I recall, those were some more of these specialists who felt that their services were not remunerated well enough in Canada. But net overall, physicians, there's been a huge number of return of physicians to Canada, and we do not see a net drain of Canadian physicians to the U.S.
Okay.
The trend is, in fact, the other way. We have
We're getting a drain?
The Canadian physicians are returning to Canada rather than staying in the United States.
Okay, but now what I understand, though, in Canada, when they initiated their system, their primary care doctors saw a huge leap in pay, about 35%, and then the specialists saw a little bit of a drop. Would that be out of the norm of what might happen here in the U.S.?
Well, first of all, speaking to my own specialty, emergency medicine, the pay rates and total income in Canada is about equivalent to the United States.
Okay.
I believe in Canada, or what we certainly need to see a direction go, is to better remunerate primary care doctors. And some of our specialists probably do need to not make quite as much as they do.
Okay.
It's very valuable to have primary care physicians. It's very important to have specialists also, but this is sometimes touted as a strength of the U.S. system, is that you don't need to wait for a knee replacement. Well, because we have a whole host of orthopedic physicians, for example, in the U.S. I've personally qualified for a knee replacement for 2 years. I've chosen not to do it. If I was in Canada and ultimately had to wait for 3 months or 6 months to get my knee replacement, that is a matter of zero medical consequence. What does need to get taken care of in Canada, emergency procedures, emergency room visits, coronary bypass grafts, those do get taken care of. If you wait for a knee replacement, that's a matter of zero consequence.
Dr. Cotton, I'd like to change the tenor of this conversation right now. I've heard that 70% of the bankruptcies that take place here in the United States are due to health care or lack of it, being underinsured. You find any truth in that?
I believe that statistic is about correct. About 70% of all bankruptcies in the U.S. are directly related to health care costs, and the great majority of those bankruptcies people who thought they were insured.
Or
they had insurance, but it was what we call underinsurance.
Mm-hmm.
Now, what is underinsurance? I mean, I understand it means not having enough insurance, but people are paying into these insurance policies a high dollar premium, and yet you're saying that they're not getting quality insurance for the care that they need.
And unfortunately, they don't know that until they have a kidney stone or their child has appendicitis. But even under the Patient Protection and Affordable Care Act, if I've got the terminology correct, I think called the bronze level plan, which is the plan that the Affordable Care Act demands that people be offered, still is what we call 60% actuarial cost, meaning it covers 60% of the bills, and that is after you've paid all your premiums and your deductibles, which for many families can amount to $15,000 to $16,000 a year, which a kidney stone, a child with an appendectomy can bankrupt.
Well, if we're going to look at the single-payer plan, how will that help?
Well, I can tell you that.
I missed your question.
My question was, let's take a look then at the single-payer plan. You were saying that with the insurance companies picking up possibly 60%, still leaving 40% for the patient to pay. How will single-payer help with picking up that 40%?
Single payer, depending how you set up the system, either pays all the bills or a high percentage of the bills. Even Medicare right now is not perfect. I mean, I've written columns so that one easy way to fix our healthcare system, you don't have to write a 1,200-page bill, is just go to the Medicare statutes, and everywhere it says 65 and over, erase that and replace with at birth. So you're eligible for Medicare at birth. But even so, Medicare still leaves a lot of expenses that the patient himself has to bear, particularly drug-related. And with our Medicare Part D program, that was a gift to the pharmaceutical companies passed, I believe it was 2003, that Medicare is not even allowed to negotiate, is forbidden to negotiate with the pharmaceutical companies for prices. This was a giveaway to the pharmaceutical industry.
Yeah. And Eric, some of the things that happen when we're looking at those insurance plans, the underinsurance is becoming the norm. The average cost for a family policy today is $15,000 a year, almost $16,000 a year. And employers cannot continue to absorb the increases that we're seeing.
Right.
When you've got 9 and 10% increases each year. So more of the cost of that policy is being shifted onto the employee. They're picking up a larger share of the premium. In addition to that, the trend in insurance in coverage is to go for the higher deductibles because those policies cost less, and also to go for the higher copays. I mean, my insurance has put a copay on everything, including sneezing. I think it costs me $25 to sneeze. But those costs add up.
Right.
And that, in that system, and people think, well, I've got insurance, but then they don't realize, let's say they have an emergency, and you go to the emergency room and you're cared for, but the radiologist isn't in your network, or the cardiologist isn't in your network, and this happens quite often with the specialists that might treat you and that might need to treat you in order to truly care for you. Or some of the procedures and the tests or the things that they did for you are uncovered services. And then add that on to, all of a sudden you've got to pay a $2,000 or $3,000 deductible and 40% of the costs of the things they did cover, plus all of the things that they said were uncovered or out of network.
Okay, well, Dr. Cotton, she's given a great example on that. But most people are going to say that it's better to have some sort of insurance versus not having any at all. And you as a doctor, I mean, you know that a person does need some sort of coverage. Otherwise, we face the other scenario of like getting them in and getting them out, treating what the problem is and not really helping them in any preventative care. What have you got to say to that?
I would agree with you, and that's why I am with great trepidation and holding my nose, so to speak. I'm a supporter of the Protection and Affordable Care Act, because it is an increment, a tiny increment, perhaps better than our system now, and that more people will be covered under insurance, but it's still by no means single payer, which is what we need. Mm-hmm. And what we've found is that when people, Deb had mentioned the co-pays and the out-of-pocket costs, and the Physicians for a National Health Program has done a number of studies on this, and they've all found that the more that the cost is of the patient to go to the doctor to get their medications, to get their routine care, the more that it just doesn't happen. And your average, so many families these days are just absolutely stretched to just take care of the minimum, and they tend to forego these needed health care visits if the financial barrier is too high. And what we're building into a system is where the financial barrier gets higher and higher and higher as more costs are passed to the patient.
Well, Metro Hospital in Cleveland, they went through their records, and they now have electronic prescriptions where they just send them into the pharmacy via email or, through the computer. And by doing that, they're also able to track how many of those prescriptions get filled. And among their Medicaid or their low-income uninsured people, they found that there's only a 50% fill rate. And that's due to the cost that they have to, the part of the cost that they have to bear themselves. And because that cost is a barrier to them, that's probably a decision that they're making between buying their medication and feeding their children that evening.
I can cite just an example again because, I'm face-to-face in the emergency room with the people that are left out of our system. As I can remember one gentleman in particular that he was a truck driver and had gotten laid off from his company where he did have good insurance, was now working for a secondary company during the 2008 economic crash, and he did not have quite as good insurance in the second company, that very poor insurance. He had chest pain, came to the emergency room. He did have some indications that he either had a small heart attack or was very much on the edge of actually having one. And he realized that it doesn't even have to be an expensive stay in the hospital, that if I was going to put him in the hospital, which he definitely needed, and by the time he gets a stress test, which is really push on a treadmill and exercise you to see how likely you are to develop chest pain or heart attack, he was aware that the cost of that was going to bankrupt him and his family with the insurance that he had, and he was almost signed out from the emergency room against medical advice out of concern for finances. And I'd have to tell him, look, if you die, then you're really hurting your children. And he, it's just that is the crux of the problem, centered in one patient. Multiply that by hundreds and thousands of millions of cases of people who are having to make decisions between their health and their finances.
I've got to ask a question because you brought up a really, really important decision that a person has to make. Either sign yourself out against medical advice and don't incur the cost and possibly die and then really put your family under a strain, or accept the care, incur the cost, and still put your family under a strain. That's an amazing decision that a person has to make. I mean, that stress alone could kill a person. No, I'm being very
Yeah,
serious.
you are, and and it's an ironic choice that person has, and the people that talk against this quite often they've never been faced with that, or they don't understand how hard it is, for the majority of people out there when you're looking at what the majority of us have as an income level in Ohio. The median household income is $47,700. Half of us live on that or less. And that's household income, it's not individual.
Right, right.
And when you're in that bottom half of that income level, you have some really tough decisions to make on a daily basis.
Yes, yes.
So I see, and I see this every day. The examples like that case I cited every single day. I see the server, the waitress who has diabetes, who is just hoping that she can, cut her medications in half and get by because she has to take care of her children.
Mm-hmm.
She has no insurance, husband left. I mean, multiply these by millions and millions and millions, and it's immoral. It's just wrong that in this country that people suffer and get sick because their economic status.
Since you're a doctor, now you just mentioned about people that, it's not just the waitress that's cutting her medication in half, but you've got your elderly that are doing it too. Mm-hmm. And those that are possibly out of work who have gotten some medication and they're cutting it in half. And yet overseas, the cost of medication seems to be so much lower. This is just what I've heard in countries such as Africa or your third world countries,
or
Dominican
Canada.
Republic and Canada and all. And not to say that Canada is a third world country, but outside of the United States, our pharmaceutical companies are actually pushing the limit to see how much they can drain the American public of. Why is that?
Capitalism.
Yeah, we put up with it. We put up with it.
Okay.
The idea that healthcare and medications is something to be profited out of rather than a human need, that it is our moral responsibility to each other to take care of. In fact, during the making of the Patient Protection Affordable Care Act, there were some attempts to make it okay for American citizens to import drugs from Canada. The pharmaceutical companies just lobbied heavily against that. The health insurance companies spent $1 million a day during 2009 when the healthcare reform was being crafted to make sure that the public option got stomped out, so that they were scared to death that people might realize that we really don't need these health insurance companies. They are profit-seeking, parasitic middlemen who eat up 31% of all healthcare expenses and really provide nothing. We don't need.
But they're lobbying against these laws coming in that will change that. But
they're lobbying against their policyholders. The people that are paying the premiums, that are giving them the money to hire the lobbyists, are the ones that they are lobbying against.
But the point I want to make is that the elected officials are the ones who ultimately speak for the people. They're the ones that are actually being elected by the people, and yet nobody's taking this fight to them, or at least to a point where they have to, reckon up and say, yes, I did vote against that, or yes, I did stand against that. So, where does the average Joe stand at? Where does the middle class and lower class citizen stand?
Well, it's interesting, and not to enlarge the subject way past, my daily experiences as an emergency physician and enlarge it past healthcare, but to really understand one facet of a system, healthcare delivery, is to in fact gain insight into the whole system. And our whole political system has become so much the big spender and big money calls so many of the shots. I mean, in the Citizens United healthcare, Citizens United Supreme Court decision that allows corporations to just pour unlimited amounts of secret cash into elections distorts the system terribly. And the Patient Protection and Affordable Care Act was basically crafted by the health insurance companies to see to it that their interests, not the patient's interests, but see to it that their interests were taken care of, and the pharmaceutical companies.
Okay.
And the bottom line on all of that, with the politics in it, is that we the people let that happen.
Yes.
We the people have a responsibility to be involved in our government besides just going out to vote every 4 years, we need to be actively involved in keeping in touch with our elected representatives and holding their feet to the fire on these kinds of issues.
Okay. I still want to ask another question now. Debbie and I were talking prior to the show, and I do believe that our insurance companies and the healthcare system as a whole actually sees that there's going to have to be a change eventually. They're fighting it as long as they can. But what do you as a doctor see? Do you see that single payer will in fact become the standard?
You're asking if I think single payer will eventually be
Yes,
here?
sir. Yes, sir.
I think that it will be eventually, just because people will eventually come to realize that the United States is basically alone in the world in thinking that healthcare is a commodity that you have to buy, and if you can't afford it, you don't get it. The United States is basically unique in that way. There are some European companies, countries, Switzerland, for example, that say that they have private systems, but it is so regulated that it's essentially not just a private-based system. So I think we eventually will, but how many more people have to die? How many more people am I going to have to see in the emergency department when I work tomorrow that I'm going to send out of the ER, and I know that they're not going to get follow-up care, they're not going to get their medications, they're not going to be able to get that ultrasound of their gallbladder, they're not going to be able to get their carotid arteries looked at, and therefore they're not going to be able to prevent the stroke that they're heading towards. And if I know that if they had insurance or if they had single payer, that everybody I send out of the ER would get their follow-up care, and they would not crash and burn and come back into the ER suffering or dead.
Well, I think one of the things is, and you keep talking about healthcare as a commodity, for sale and for profit. And we have to start thinking about healthcare as a human. Yes, it is a basic human need, and we've got to think about it as the public good. This is something the same as fire protection and the same as police protection. And it's something that we need to invest in as a society where, we said it before, we look after one another and we take care of one another. This is basic to everybody, and we will all need it at some time. I think the other thing is that we have to develop the understanding of healthcare as a human right to people.
I agree with you completely, Deb. And it's interesting that at one time in United States history, even fire protection was something that thought to be a commodity you had to pay for. If you didn't pay for it, you didn't get it.
Right, and it was a real mess, because if my house burned down and I didn't have insurance, the fire department wouldn't come out. They'd just let it burn. But Eric lives next door to me, and his house caught on fire because of mine, because nobody came to put it out. So Eric is really upset with me because...
Yeah, that's what would happen.
Yeah, he probably wouldn't let me rebuild. Not next to him. But it created a mess, and that's the same thing that our healthcare policy does. And our healthcare system depends on public policy, and we have to look at government as something where it's we, the people, coming together to solve common problems, and healthcare is a common problem that the individual cannot solve on their own.
The country was founded on we, the people, can come together and promote the common good and welfare and take care of each other.
Mm-hmm.
Me as a physician, I was born in a hospital where I'm sure that it was a public hospital. I went to publicly supported schools. My medical school education was heavily public supported. My residency, my training was heavily public supported. This was not something that I alone accomplished. And when I see speaking for health, single payer health care, as part of a responsibility that I owe to my patients and owe back to society for having taken care of me so well that I could become an emergency physician.
Well, that answers the question Eric asked me before the show started, is why does it matter to you as a doctor? You're going to get paid anyways.
It matters if you're going to. I believe in trying to take care of people and doing the job, and taking care of my patients involves advocating for them in all ways. And I know I will see them tomorrow. The patients, like I said, I will discharge from the ER that are not going to be taken care of until they crash and burn and come back to the ER again.
Yeah, and I think
we'll use all of them.
I have to say this. I have to compliment Dr. Cotton on that because I did ask that question. I really wanted to know. You hear about doctors making an extremely large amount of money, and why would they even be bothered? But I think it's good for our listeners to hear that doctors are not just willing to treat them, but even to advocate for them. Because that's not something that you're going to find throughout society. We work jobs.
Or think about them when they have walked out of the ER. I think it's comforting to know that they are concerned about us as the human being,
yes,
and not the medical specimen.
That's right.
And that, but it's also because, and Brad has exemplified this here tonight. They're not just a doctor performing a job, but they're human beings as well.
Mm-hmm.
And they're human beings that have the same problems everybody else has and the same emotions and the same, they go into that, most of them, because they care about people. Mm-hmm. And especially if you're going into emergency medicine, I think, or primary care medicine, there's that caring about people. And they go into this profession to heal. And they see that the situation here is wounding their patients as much as it's healing them.
The Physicians for a National Health Program did a study showing that the closer you are to primary care, the family practice doc, the pediatricians, the emergency physicians, the more sympathetic you tend to be to the idea of single payer.
Mm-hmm.
We're the ones on the front line.
Well, you see it on a daily basis.
Dr. Cotton, I have another question to ask you. That with the single-payer system, imminently going to come into fruition, how long do you think it's going to take? You think we'll see it in our lifetime?
Well, I don't know. The Physicians for a National Health Program, for example, has been around, if I recall, since the early to mid-'80s, and this may be something that my children may have to see, but I know that I have to do the right thing and continue writing and speaking and working and speaking the truth, whether it seems to bear fruition immediately or not.
Mm-hmm. You think it's incumbent upon every listener that tunes in and hears something about healthcare to actually take the message out and make it a hot button, push that button and make it a topic worth talking about, has to be talked about?
I would say yes, and Deb hit on this earlier. We need so many of us to become cynical about our ability to have effect, and when we teach cynicism on government, like don't even bother to vote because it won't make a difference anyway, they're all just crooked. But in fact, if we don't vote and don't speak, then we give the special interests, we give the lobbyists, we give the insurance companies, the pharmaceutical companies, the people with the big bucks, we give them more power when we give up.
Mm-hmm.
That's true.
Well, and that's one of the principles of democracy. Forget exactly what the term is now, but I learned this when I was helping my niece do her homework one time. But the power really does rest with the people. The only time that the people are powerless is when we turn that power over and we don't monitor the power we've given to our elected officials. But we saw the evidence of the power resting with the people here in Ohio a couple years back with Senate Bill 5. Which was passed, which was a very unpopular measure that was passed by the state legislature and signed by the governor, and the people got the petitions out and they got the signatures they needed for a referendum, put it on the ballot, and they overturned that law by a 2-to-1 margin. So when the people are motivated to do it, the people can take charge, and the power really does rest with us. We just have to take it.
And with groups like the Ohio Single Payer Action Network, if we're going to get to single payer, it may have to begin in states, although it's somewhat technically difficult to get it done well because there's so many federal statutes. Vermont, for example, is wrestling with this. But,
right.
We have to start there, perhaps.
Mm-hmm. Well, and there's a lot of thought for that. And I think, one of the things that SPAN Ohio does is we not only advocate for the state bills here, but we also advocate for a national bill, because that is our ultimate goal, is to have a national plan so that everyone in this country is covered, just like the other developed countries. And that we think our people should have the same. There's something... there was an article in the Washington Post, and it was about our healthcare statistics. We come in dead last when it comes to mortality or life expectancy. Now, we do rate number one in a couple fields. We rate number one in cost, and we rate number one in the number of violent deaths that occur in the 17 countries that were studied. But there was a statement made at the end about why this exists, why there is such disparity in the United States, why so many people don't have access, and why we have not created a system that cares for everybody. And the statement was, the big question raised by the data in this study is how Americans have allowed themselves to sink to the bottom of so many indexes that measures the quality and duration of our lives. What's truly exceptional about America, it turns out, is the indifference we show to our compatriots, the absence of the kind of national solidarity more evident in the nations that surpass us on all these lists.
I urge people to, next year when it comes out, to read or watch Charles Dickens' A Christmas Carol.
Mm-hmm.
Tiny Tim basically was on his way to dying for lack of health care because his father didn't make enough money, and
Mm-hmm.
I've written columns about this. There's a movie, It's a Wonderful Life.
Right.
Instead of the Bailey brothers building a loan, which was a model for capitalism that people that cared for each other and took care of each other, we've decided that Mr. Potter, the one, and the country has thus become a Potterville.
Mm-hmm.
You get my reference there, but one thing I just want to address very briefly is sometimes the political opposition is so good at demonizing government, about you're going to lose your rights, you're going to lose your choice. Single-payer health care, if done correctly, the way Canada does, the way Medicare does not limit choice of doctors. The doctors are not government employees. If you know somebody has Medicare, unless they have one of the Medicare Advantage plans, one of the
Mm-hmm.
privately administered plans, which actually cost the taxpayer more money. The privately administered Medicare Advantage plans, the patient starts to lose some choice. But people that are on traditional Medicare, they can choose their doctors, they can choose their hospitals, they can make all their health care decisions as the way they and their physician would like to. The only thing is that the payment is Medicare.
And that's the only thing that
It is not some Stalingrad type, Marxist-Leninist system where the government's making all the decisions. It's not frightening at all. What's frightening is the people that are on the Medicare Advantage plans who start to have limited choices.
Or the traditional insurance.
Where your decisions are being made based on what is profitable rather than what you need.
Exactly.
Dr. Cotton, it's been really good having you on the air tonight. I got to tell you, you brought to us a lot of enlightenment on Medicare, especially from a doctor's point of view. We do want to wish you the very best of encouragement, in all your endeavors. We do appreciate the fact that you have come on, and I do want to take the time out to give Debbie room to talk about some of the things that are going to be happening around the state here in Ohio.
Well, we've got a number of things that are going to be happening. First of all, I want everyone to save the date, April 27th, because that's the SPAN State Conference in Columbus, and we're going to have a wonderful program, something there for everybody, and we hope that you'll join us. You can check our website. There will be information coming out shortly, and the SPAN website is spanohio.org. Also, there's a play that's going to be touring the state called Mercy Killers. It was written by a Columbus native, Michael Milligan, who is a Broadway actor and playwright and also a drama instructor. And he is bringing this play to Ohio. He will be performing it free of charge, and it will be in Columbus primarily for a 3-week period, but he's also taking it on the road to various locations in the state. And again, you can check the SPAN Ohio website to find out more information about that. Next month, we hope that you'll all join us for a discussion on those Medicare Advantage plans and just how much they've bilked the taxpayers for. Also, for additional information about health care reform, you can visit the following websites. The SPAN Ohio website, again, is www.spanohio.org. Physicians for a National Health Program has a wealth of information, and they are at www.pnhp.org. And Healthcare Now, which is a national organization dedicated to healthcare reform nationally, single payer nationally, is www.healthcare-now.org.
And with that said, I'd like to remind our listeners about the comment block that you'll see just below this broadcast. You're able to make comments, and they will be monitored live. We will respond back to you, so go ahead and get your questions, comments, beliefs, unbeliefs in, and we'll get an answer back to you. Again, I want to thank Dr. Cotton for having appeared on Healthcare for All, and I'd like to wish everybody a good night.
Same to you.